Hi guys, welcome to Podcast Med. The topic of discussion in this podcast is poisoning. We will discuss about the poisoning in the following headings. Okay, firstly, we will be discussing about how to evaluate a poison patient. Comprehensive evaluation of the poison patient. The second thing we will be discussing about is the management of poison patient. Then we'll be discussing about specific poisons. One of the poisons that is phosphate poisoning, which we already have discussed in the previous podcast. We'll be discussing about remaining poisonings, like pharmaceutical agents and all. Coming to the comprehensive evaluation of the poisoned patient, so we'll be looking for 8 things here. Any patient who comes to the OPD, we should be checking their primary things that we should check for is respiratory rate, oxygen saturation, pulse, BP, and other vitals. Along with, we'll see for any arrhythmias. Okay, arrhythmias regarding circulation thing, ABCDs that we already all know. And then coming to the level of consciousness. Level of consciousness we will be seeing if there are any presence of seizures, delirium if it is there, agitation or psychosis if present. Then coming to chest, in chest we should see for evidence of aspiration, bronchoconstriction, etc. Then coming to the movement and muscles, we'll see for tone, fasciculations, myoclonus, tremors, paralysis, ataxia. Then coming to the reflexes, we'll see tendon reflexes, plantar responses, inducible clonus, if all of these are normal or not. Then coming to the eyes, we'll see for miosis, midriosis. This is in most of the poisons, the eyes will be affected. Like there will be miotic eye, midriatic eye, or pinpoint pupil, like few conditions we see, like that. And then coming to the other things in eye, miosis, midriasis, diplopia or strabismus, and also for lacrimation. And if the poisoning is cholinergic poisoning, there will be lacrimation in general. Then coming to the abdomen, in abdomen we'll be seeing for hepatic or epigastric tenderness. Why will we see this? Hepatic tenderness and epigastric tenderness we'll see for liver involvement here, and any other causes for this. And coming to the other things in abdomen, that is we'll see for ileus, palpable bladder, if they're normal or not, and if there is palpable bladder because of urinary retention or any other things. Then coming to psychiatric evaluation, we'll see for any psychiatric illnesses, mental capacity, because most of the people who get poisoned, few of the psychiatric patients will have suicidal symptoms. Okay, so most of them will try to poison themselves in suicide. So we should evaluate their psychiatric status as well. Then coming to the mouth, we should see for mouth dryness and if there is any excessive salivation which we see in cholinergic poisonings. Then coming to the last one, that is skin we see for temperature, cyanosis, flushing, sweating, blisters, pressure areas, piloerection, evidence of self-harm if any present, like any hesitation, cuts if present, we'll see for that. And we'll also see for few of the needle tracks, because needle tracks are present in the people who do substance abuse, like opioid, morphine, any of the drugs of abuse if they are using. Then coming to the next thing, while taking history, we should be asking these questions in particular. Okay, that what toxin have been taken and how much, what he have took, like what time, and then what time were they taken and by what route, how he took it. And have alcohol or other substances including drugs of misuse also been taken, any other substances are taken or not. Then we'll be obtaining details from witness about his family, friends, ambulance personnel, and of the circumstances of overdose, if there is any overdose happened and what happened on the way of getting the patient here. Then we'll assess the immediate suicide risk in those with apparent self-harm. If they are trying to harm themselves, we'll be seeing for suicide risk in them. And then we'll assess the capacity of the person to make the decisions about accepting or refusing the treatment. We can accept or not, because so many people who poison have psychiatric illnesses maybe. And establish past medical history, drug history, allergy history, social history, and family history as well, and record all the information very carefully. Then we'll go with the clinical assessment and investigations. We'll be doing so many things like this patient may have a cluster of features like toxidrome. That cluster of clinical features is called toxidrome, suggestive of poisoning with a particular drug type, such as anticholinergic, serotonergic, sedative, stimulant, opioid, cholinergic feature clusters. So we'll assess all of this clinically and we'll send the samples for investigations. Then coming to the few things here I want to mention, or there are few causes of acidosis in poison patients, like acidosis, metabolic acidosis basically, okay, where there is increased lactate levels, and in few cases there will be acidosis but there is normal lactate levels. We'll see what are they. The names, the examples of poisonings with normal lactate and acidosis patient, we have salicylates. For example, what is salicylate? Example of salicylate, it is aspirin. Then salicylate, methanol, ethylene glycol, paraldehyde, and the other thing is high lactate levels with acidosis patient. It is present in metformin, iron poisoning, cyanide poisoning, sodium valproate poisoning, carbon monoxide poisoning, etc. All of these will have acidosis in poison patient. And then coming to the general management, we will see firstly eye or skin contamination should be removed by local decontamination measures. Okay, we'll first do gastrointestinal decontamination. This can be done by so many ways, like activated charcoal can be given in patients with impaired swallowing or reduced levels of consciousness. Activated charcoal given via a nasogastric tube carries a risk of aspiration pneumonitis. There can be a risk of aspiration pneumonitis, but that can be reduced, and that does not say that the risk is completely eliminated, and it can be reduced by protecting the airway using a cuffed endotracheal tube. Okay, then multiple doses of oral activated charcoal, that is 50 grams of activated charcoal 6 times daily in an adult will enhance the elimination of substances. But this activated charcoal will be best if it is given within 1 hour of overdose. Okay, if it is given after that, the efficacy of this might decrease so much. Then we can also do gastric aspiration and gastric lavage and aspiration. This is contraindicated in few specific poisonings, like acid poisonings. If there is any acid poisonings, if there is any strong alkali poisoning or petroleum distillate poisoning, etc. Then coming to the next thing, gastric lavage and aspiration, that is done. We'll do lavage. Then we can also do whole bowel irrigation. This involves administration of large quantities of osmotically balanced polyethylene glycol. We'll be giving polyethylene glycol and electrolyte solution at a rate of 1 to 2 liter per hour in adult. Okay, usually it is given by nasogastric tube until the rectal effluent is clear. We should see until the rectal effluent is clear, there is no things like that. And it is contraindicated in few of the conditions where there is inadequate airway protection, hemodynamic instability, gastrointestinal hemorrhage, obstruction, or ileus. Then the next method is urinary alkalinization. We will administer sodium bicarbonate. Example, 1.5 liter of 1.26% bicarbonate, sodium bicarbonate is given over 2 hours, for example, in few things. We can also do urinary alkalization in weak acids like salicylates, methotrexates, and it will enhance the urinary excretion. And this urinary alkalinization is currently recommended for patients with clinically significant salicylate poisoning mainly. Okay, what is example of this? Aspirin poisoning. If the patient is having, we can easily do urinary alkalinization. when the criteria for hemodialysis is not met, we will do this if there is no chance of doing hemodialysis. The other things, as we just now discussed, hemodialysis and hemoperfusion, we'll be doing this also. And then we can even do lipid emulsion therapy. Lipid emulsion therapy, it involves intravenous administration of 20% lipid emulsion. Okay. And the lipid soluble toxins partition into intravenous lipid reducing target tissue concentrations in this case. Because of this, we use lipid emulsion therapy. Then we will obviously do supportive care, antidotes. There are specific antidotes for specific things. Okay, we'll be discussing about specific antidotes. Coming to the antidote and its drug or poison and its antidote. Coming to that, we have naloxone, used to treat opioids. We have flumazenil, which is used to treat benzodiazepine poisoning. Atropine for treating organophosphorus and carbamate poisoning, as usual. Then coming to this other things. For paracetamol poisoning, we use acetylcysteine or methionine. Mostly we will be using acetylcysteine though. And for isoniazid poisoning, we will use pyridoxine. Then for warfarin poisoning, vitamin K. Ethylene glycol poisoning, fomepizole. Methanol poisoning, ethanol is used. Organophosphorus poisoning, we can also use oximes, that is pralidoxine, obidoxine. And for methotrexate poisoning, the antidote is glucarpidase. All of those things that we have just now read, we might have heard it prior also, but this thing, remember, methotrexate poisoning, we give glucarpidase. Cyanide poisoning, we give sodium thiosulfate. Then also for cyanide poisoning, we can also give hydroxycobalamin dicobalt editate. Okay. Also, we can give sodium nitrite as well. Then coming to lead poisoning. Lead poisoning will give DMSA. Then we'll give protamine for heparin poisoning. Dioxin poisoning के लिए हम dioxin FAB fragments use करते. Then the next thing is specific poisonings we'll be discussing about. Coming to the paracetamol poisoning. Paracetamol, the maximum dose in a day that the paracetamol dose that we can take during the day is high only, but if it is repeatedly taken and the paracetamol toxicity occurs, it is because of the accumulation of NaPQI. NaPQI, it is a byproduct or end product of the paracetamol, what is that called, detoxification. Okay. This chemical, whatever is there, NaPQI, it will go deplete the hepatic glutathione, and it will hamper the liver functioning, so poisoning occurs. So to treat this, activated charcoal can be used in 1 hour, and the specific antidote for this is acetylcysteine basically. So acetylcysteine, what will it do? It will go replenish and replace and restock the hepatic glutathione and reverse the situation. Then we will also do arterial blood gases and lactate assessment in patients with reduced bicarbonate or severe liver function abnormalities. Metabolic acidosis in this will indicate severe poisoning. If there is multiple ingestions of paracetamol over several hours, this is called staggered overdose, okay, or days. If it is taken over days, it is chronic therapeutic excess. If it is taken over several hours, it is staggered overdose. So acetylcysteine will be indicated, but paracetamol treatment nomograms are not useful for assessing this. Normally, acute poisoning, if the patient has taken bunch of tablets together at once, this will be treated with acetylcysteine in nomograms. Okay, this is not useful if it is chronic therapeutic excess or staggered overdose. Okay. Non-allergic anaphylactic reactions are the most important adverse effects of acetylcysteine, and it is due to dose-related histamine release in this acetylcysteine intake. Then we'll go with aspirin poisoning. Aspirin poisoning, nothing very specific about it is there. Just the same things that we have discussed. There are specific antidotes for this, and in this there is metabolic acidosis. It should be treated by intravenous sodium bicarbonate. Alkalinization should be done. There are other poisonings here given like non-steroid and NSAID poisoning, antidepressants like TCA, tricyclic antidepressant poisoning, SSRIs, selective serotonin and noradrenaline reuptake inhibitors ka poisoning, lithium poisoning, beta blocker poisoning, calcium channel blocker poisoning, digoxin poisoning, iron poisoning, anti-diabetic agent poisoning. We should remember one thing, that anti-diabetic patients may what happens, few drugs for anti-diabetic and which acts anti-diabetic will cause hypoglycemia, because in diabetes there is hyperglycemic state. As we try to reverse it, there may be hypoglycemia with a few drugs overdose. So it should be very consciously maintained. Then coming to the next things, we have benzodiazepine poisoning, opioid poisoning, amphetamines, stimulants and entactogens, dissociative drugs, volatile substances. And we'll talk about body packers and body stuffers. Okay. Then we have carbon monoxide poisoning, hallucinogen poisoning, OP poisoning that we have discussed already. That we have two phases over there: acute cholinergic three phases: acute cholinergic syndrome, intermediate syndrome, organophosphate induced delayed polyneuropathy. All of these are there. And then we have poisoning with corrosive substance, acid poisoning, aluminum and zinc phosphide poisoning, and all of these things. Food related poisonings, fish related poisonings, plant poisonings, fluorosis, arsenism. All of this we already have studied in FMT, forensic medicine toxicology. If any one of you are not able to remember those, then go check out your FMT textbook, read from that, because the whole toxicology is about this poisonings and treatment and what happens in that poisonings. So we'll discuss about it in that thing. Okay. This is about the poisoning and drugs of misuse. So this is it for this podcast. Thank you. Medicine toxicology, but I wanted to say that body packers and body stuffers. Basically, in body packers, what they will do, they will swallow the packets of drug that has to be transported, and there will be some mechanism to bring them out. Okay, so they will swallow.